I am Dr. Selvaraj, your surgical educator from Coimbatore, India. Welcome back to my series of surgical teaching video class. These are meant mainly for medical students, surgical trainees, and junior surgeons from all over the world. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today in this video, I am going to discuss one more cause for obstructive jaundice, that is peri-ampullary carcinoma. So I am your surgical educator. Today we will talk about the peri-ampullary carcinoma. This term refers to malignancies arising from within 2 centimeters of ampulla of Vetter, the critical junction where the bile and pancreatic ducts drain into the duodenum. It is a diverse group of cancers that all present similarly with obstructive jaundice, but they differ significantly in their origins, biology, and prognosis. Understanding this difference is the key to their management. So, what is the learning outcome or what you are going to gain after watching this video? So, you will be able to understand the different causes of lung obstructive jaundice, the epidemiology, etiopathogenesis, clinical features, investigations, staging, and treatment of peri-ampullary carcinoma. Of course, as usual in any other didactic videos, I have included a mindmap, a mind map, a treatment algorithm, and I have also included take home messages. So, what are the different causes of obstructive jaundice? Broadly, you can divide it into intraluminal cause, mural cause, and extramural cause. Intraluminal causes are choledocholithiasis, Clinarchis sinensis, and ascariasis. The mural causes are biliary atresia, that is congenital cause, malignant stricture, that is cholangiocarcinoma, or benign stricture, sclerosing cholangitis. The extramural causes are carcinoma head of the pancreas, peri-ampullary carcinoma, and portal lymph node. This is nothing but the secondary lymph node in the portohepatis because of primary malignancy anywhere in GIT. Coming to the different types of peri-ampullary carcinoma, even though it is a single clinical identity, anatomically, this peri-ampullary carcinoma can develop from 4 different areas. One is from the ampulla, that is ampullary carcinoma, or from the distal CBD, that is distal cholangiocarcinoma, or from the pancreatic head carcinoma, or the duodenal carcinoma. So, all 4 are different areas, but all of them will present as peri-ampullary carcinoma. All of them are arising from the epithelium in that area. From a surgical perspective, all are grouped together. The presentation is usually progressive painless jaundice. All of them requires pancreatoduodenectomy, but prognosis varies differently. Because the ampullary carcinoma present very early, prognosis is better in ampullary carcinoma than the pancreatic head carcinoma. Epidemiology and etiology. Epidemiology, pancreatic head carcinoma incidence is 70 to 80%, the most common and most aggressive. Ampullary carcinoma 10 to 15%, best prognosis due to early presentation. The distal CCA in the common bile duct, 5 to 10% intermediate prognosis. Duodenal carcinoma is less than 5%, the rarest among all 4 varieties. The risk factors: elderly people, those who are more than 60 years old, those who are smokers, a very major modifiable risk factor. Those who are having chronic pancreatitis, especially the hereditary relapsing pancreatitis or calcifying pancreatitis. Obesity and diabetes, those who are having genetic syndromes like familial adenomatous polyposis or Hoover-Jagger syndrome. These are all risk factors to develop peri-ampullary carcinoma. What are the clinical features? All of them will be having, except the pancreatitis, the ampullary carcinoma and distal CCA, because the tumors grow into the ductal lumen. This will present with jaundice earlier. So prognosis is good. Whereas pancreatic head carcinoma, the tumor grows outward, so they will present as not jaundice to begin with. If it is jaundice, that means it's an advanced case already. So apart from this presence of jaundice, they will be having also the curvaceous gallbladder or the palpable non-tender gallbladder. That also will be is there. Coming to the investigations and staging, the initial imaging is abdominal ultrasound that confirms the bile duct dilatation, and it also suggests the level of obstruction. And then the high quality multi-phase CT scan, or we have to do MRI to rule out any vascular involvement or distant metastasis. Endoscopic ultrasound to find out the local staging status, the level of invasion of the wall of the bowel can be determined best by endoscopic ultrasound. We can also do biopsy, lymph node involvement also you can see, you can do FNA biopsy also. ERCP also you can do, you can place a stent, but usually pre-operatively we should not put a indwelling stent. That will increase the incidence of infection. So nowadays we are not doing it. Tumor markers CA19-9 and CEA also, both will be elevated. Particularly this CA19-9 will be more elevated in case of pancreatic head cancer. It is used mainly for monitoring only, that is for surveillance. It is not, confirmatory. Coming to the treatment, all of them, they need the same procedure, the Whipple's operation. But we have to decide whether the tumor is resectable or not resectable. If it is resectable, okay, we have to do pancreatoduodenectomy, in which case you will be removing the head of the pancreas, duodenum, CBD, gallbladder, and adjacent lymph node. All these things should be removed, and we have to do 3 anastomosis: pancreatojejunostomy, hepaticojejunostomy, and then gastrojejunostomy, or if you are doing pylorus preserving Whipple's operation, then we have to do the duodenojejunostomy. If it is an unresectable disease, then the treatment is only palliative, focusing on the biliary or gastric outlet stenting. Plus, we can also give chemotherapy. Coming to the prognosis, the ampullary variety, the 5-year survival rate is 40 to 60% in the RO resected patient. Okay, present, because these cases present early and these are less aggressive. So the 5-year survival rate is 40 to 60%. Whereas in case of distal CCA, the 5-year survival is 20 to 35%. It is intermediate aggression. The duodenal carcinoma 5-year survival rate is 30 to 40%, and in pancreatic head carcinoma, the 5-year survival rate is 15 to 25%. This is highly aggressive tumor. So importance of subtype. While all patients undergo same operation, prognosis vary dramatically depending on the tissue of origin. Already I told you ampullary carcinoma, the best prognosis, 40 to 60% survive. Pancreatic head carcinoma, worst prognosis, 15 to 25%. And coming to the key takeaways, in summary, remember these key points about peri-ampullary carcinoma. Even though it is a single clinical entity, it comprises of 4 areas of malignancy, that is pancreatic, ampullary, distal, CBD and duodenal, all presenting in the same location with the same carcinoma, that is painless, progress, painless intermittent carcinoma, and pain. It is not actually progressive. This is wrong. Painless intermittent, because why it is intermittent? The ampullary carcinoma will outgrow the blood supply and it will get necrosis. So what will happen? It will suddenly the jaundice will disappear and then again it will recur. So it is painless and intermittent jaundice, not progressive. The definitive treatment for all the 4 variety, if it is resectable, it is pancreatoduodenectomy. The ampullary carcinoma has got best prognosis, 40 to 60% 5-year survival rate, whereas the pancreatic carcinoma has got worst prognosis with 15 to 20% of 5-year survival rate. So thank you for joining this didactic lesson. Now, this one is the mind map. Whatever I have told you so far, so here I am going to show you in a single mind map. What are the 4 types of carcinoma? Ampullary 10 to 15%, distal CCA 5 to 10%, pancreatic head CA is the commonest 70 to 80. Unfortunately, it is the most aggressive tumor. Duodenal is less than 5%. Risk factors: elderly people more than 60 years, smokers, chronic pancreatitis, obesity and diabetes mellitus, genetic syndromes like FAP and Hoover-Jagger syndrome. Clinical features: the ampullary and distal CCA variety will present with the early jaundice, painless and intermittent jaundice also. Clinical features of carcinoma head of the pancreas, late jaundice. These people will present with abdominal and back pain. Purvoisius sign, that is non-tender enlarged gallbladder, is palpable. Investigation: abdominal ultrasound will show dilated CBD, suggesting the level of the obstruction. Triple phase CT or MRI you have to do to rule out any vascular invasion, the nodal status, or distant metastasis. UUS to do accurate staging and also taking biopsy. ERCP, direct visualization of the tumor, and we can take biopsy also. CA19-9, very much elevated in pancreatic variety, used only for monitoring purpose or the surveillance. Treatment: if it is resectable, for all cases we have to do pancreatoduodenectomy or Whipple's, where we have to resect the pancreatic head, duodenum, CVD, gallbladder, and adjacent lymph node also. And we have to do 3 anastomosis: pancreatojejunostomy, hepaticojejunostomy, gastrojejunostomy, or if it is pylorus preserving whipples, then duodenojejunostomy. Among these 3 anastomosis, pancreaticojejunostomy is notorious to go for post-operative pancreatic fistula. The 5-year survival rate, prognosis for ampullary cancer is 40 to 60%, the distal CCA 20 to 35%, duodenal 30 to 40%, whereas for pancreatic head it's only 15 to 25%. So this is the treatment algorithm. See, peri-ampullary carcinoma. What is the history? Abdominal back pain, laboratory studies, liver function, CA 19-9. You have to do spiral CT. Consider endoscopic stent if jaundice and US biopsy. But nowadays, pre-op endoscopic stent we are not using routinely because of increased incidence of infection. We are not doing any stenting. Carcinoma of the bile duct, ampulla or duodenum. If it is resectable, what to do? If it is unresectable, what to do? If it is pancreatic carcinoma resectable, what to do? Pancreatic or duodenum. If it is unresectable, what you have to do? Everything is there. You can just, I have told you everything. So you can pause the video, you can read everything. So thank you very much for watching this video. If you think that these videos are very helpful, kindly share these videos in your social media and subscribe to this channel. Kindly press the bell button also to get notified regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.